evening, and thank you for joining us at All About Us Radio, where we're here to change you, change us, and change the world. Tonight, our topic is going to be on mental health and psychosocial issues and how we can make a change for our community. Tonight, I have two dynamic speakers who will be joining us. I have Dr. Javier Jimenez and Julissa Dixon. Dr. Javier Jimenez is Director of Consultation Liaison Psychiatry at the Long Island Jewish Medical Center. He completed a psychiatry residency at the University of Pittsburgh and did a psychosomatic medicine fellowship at Mass General at Harvard Medical School. Prior to joining Northwell Health 1 year ago, he worked as a consultation liaison through the Cleveland Clinic for over 7 years, where he served in a number of liaison psychiatry roles within the department, ranging from epilepsy, spine and orthopedic issues, dermatological issues, bariatric issues for those people who are overweight, and transplant. He also served as the director of the Chronic Pain Rehabilitation Program and the department in the Neurological Institute. He is a fellow of the Academy of Consultation Liaison Psychiatry and is academically active in various forms of intersection between medicine and psychiatry, focusing on things that are extremely important to our community: chronic pain, functional somatic syndrome, medical unexplained symptoms that we don't know about or can't figure out, abnormal illness behaviors, and integrating care models. Extremely important. So tonight, I want to introduce you to Dr. Javier Jimenez. Thank you for joining us. And we also have Julissa Dixon. She's a licensed clinical social worker with a master's in social work welfare from Stony Brook. She has extensive background in medical social work as a result, and has a wide range of training and experience in working collaboratively with clinics and adjusting to life stressors. She works a lot with postpartum depression and anxiety, perinatal mood disorders, marital and relationship conflicts, chronic illnesses, aging, as well as caregiver stresses and death of a loved one. She's very passionate about helping individuals gain insight, improving self-awareness and development of healthy coping skills, and how to navigate challenges within life. She strives for a warm, self, and nurturing environment for every client. So we are very happy to introduce you tonight to Julissa Gibson, licensed clinical social worker.
Hello.
Welcome, both of you.
Thank you.
Thank you for joining me tonight.
Thanks for having us.
So, thank you. So when we think about psychological and social issues, Dr. Jimenez, can you tell me what are some of the most common psychiatric issues affecting women today?
Thank you again for having me on, and I appreciate sort of getting everyone together on this important topic. I think it's particularly important now with the sort of COVID and post-COVID era that we look at this seriously. I would say that amongst women, just as with men and other demographics, we have, a mental health crisis, an epidemic, and in our society, unfortunately, and that includes a range of conditions and situations that we'll talk about today. Everything from high stress that can manifest as anxiety, panic, depression, other problems of coping, unfortunately, a co-epidemic of substance use and addiction. And then there are some pretty serious psychiatric conditions that are going to be discussed later, including what are called psychotic disorders, schizophrenia, schizoaffective disorder, and of course, bipolar disorder. Sort of scary topics with a lot of stigma, but are important medical conditions that do affect both genders. And I think that given the sort of social inequalities that are present amongst certain demographics, whether it's minorities, women, both. The risk of these conditions is a bit higher, I would argue, and the sequelae, the problems associated with these conditions, the burden is certainly greater.
Okay. So, can you explain to me or to our audience what is the difference of your role versus Jaleesa's role, which is a clinical license social work?
It's a great question. It's a very confusing field when one tries to understand all of the different clinicians and practitioners in mental health. But you have various categories. You have physicians like myself who went to medical school and became psychiatrists as a specialist, right? Doctors can become all sorts of types of doctors, whether it's a surgeon, an OBGYN, or in my case, a psychiatrist. And with that medical background and the ability to prescribe certain medications and to do diagnostic assessments, I try to help patients with mental health disorders. I don't want to speak for Jaleesa, but of course, there are other very important members of the mental health community that are psychologists, social workers, therapists, and counselors, which she can, of course, explain more. But that's the role of the psychiatrist, is to help with perhaps really acute matters, things that have medical overlaps, and also conditions that may respond to medications.
Thank you. And so, Jaleesa, please tell me about your role and how that fits into the psychosocial world and the psychiatric issues that people face today.
Absolutely. So, as a clinical social worker, I provide individual, couples, and group therapy to individuals that are suffering with anxiety, depression, bipolar, schizophrenia. What I do is individual counseling sessions. So every day we will talk about your coping, or weekly, we can do coping skills. We can discuss grounding techniques. We can uncover your traumas and how that impact how you're coping. We can talk about life stressors and how it's impacting your day to day. So mainly, I would say we focus on the therapy aspect of it. And then we collaborate with the psychiatrist if necessary in terms of medication management. And a lot of our clients, or I should say my clients, we definitely collaborate with the psychiatrist if medication is necessary.
So I know that right now, a lot of people are having challenges, right, with trying to find licensed clinical social works, and even getting into a psychiatric center for additional help. How does one reach out within a community setting to get access to care? How does one reach out?
Well, since the pandemic, I've noticed there's been a lot of platforms that are forming. There's Psychology Today, there's Therapy for Black Girls, there is therapyforblackmen.com, there's cliniciansofcolor.org. There are different platforms that you can go on and find a clinician that's in your neighborhood. If, let's say, for example, if you are struggling with perinatal or postpartum mental health disorders, Postpartum International has a directory. And what I love about this directory is that it requires you to do a 3-day intensive long training before you're able to list yourself on that directory. And then if you as a client you're looking for someone, you can definitely go there, put your insurance, put your zip code in, and anyone that is trained specifically in this will pop up for you. So they really do a good job in making sure that whoever is listed is qualified and that they know that this person is going to take good care of you. So there's different platforms that you can utilize to find someone in your community.
And Dr. Jimenez, if you could explain to me, we've seen a rise in psychiatric behaviors since the pandemic. We have a lot more homeless people that are out and off their medications, unfortunately. How do we get and try and reach out to them? And where are places that they can go to try and get some help?
Yeah, it's a great question, and it's a huge problem. With the pandemic, we saw greater rates of a number of problems: homelessness, financial strain, substance use, suicide, unfortunately, and And as a result, our services have been swamped, whether they're in a hospital where I work or in outpatient services, as were just described. And I think the way to approach this is to really expand services, advocate for increased funding and support for unique resources that meet those kinds of demands quickly. So, for example, walk-in clinics that are open and don't require appointments, for urgent matters, much like an urgent care model for medical matters. Staffing ERs, emergency departments, appropriately with mental health clinicians so that they can help the various emergency physicians see mental health patients as they come in. In an ideal world, we'd have even more expanded models, including mobile outreach, and there are some of those models in certain communities, but we're very far from meeting the demand and the need. So it is a huge problem.
Okay. So either Jaleesa or Dr. Jimenez, I'm going to ask, young people say, I'm anxious, I have anxiety. They have a test, they're in high school. Right before I have to come on to do this kind of a podcast, I'm like, oh my God, I'm having a little anxiety myself. What is the difference between, okay, I have anxiety or I'm just a little nervous versus I have anxiety and I need help and I need to, seek somebody so it doesn't affect my life? Either one can take that question.
I'll let Jaleesa start. I do have some comments, but please, Jaleesa.
Sure, absolutely. So whenever I'm meeting with a client, we do have an assessment that we complete. Okay. And so we have criteria we follow as clinicians, the DSM-5. And so we have to make sure that the client would meet criteria. And I don't believe in diagnosing a patient or a client on the first session. I do like to meet with you and speak with you because some of these things might just be an adjustment disorder or maybe a struggle with life stressors that are going on right now, and so a lot of patients or a lot of clients aren't familiar with the difference between situational anxiety. Right now, in this particular instance, I'm feeling anxious or symptoms of anxiety versus generalized anxiety disorder. And I like to collaborate with them. We can look at the DSM-5 together. We can discuss it over sessions and we can determine together if you fit that criteria. But I do believe that it does take some time before, as a clinical social worker, before I do diagnose with generalized anxiety disorder. But it happens quite, common. It's very common.
Now, what I was going to say is it's a great question. How do you differentiate anxiety that is situational or even normal, I would say, even healthy, versus that crosses into what, we would say in medicine is a quote disorder, right? And I think Jaleesa's right. We use well-vetted guidelines and criteria to see if somebody, after one or two visits or however much time we need to figure out if they've actually tipped into what we call functional impairment, or fancy speak for they're just unfortunately just not doing well with that level of anxiety. Anxiety does have a role, right? It keeps us sort of on our toes when we have to approach a test or a podcast. And so there's some healthy component to anxiety, but if it's too much, then we tip into functional impairment. And that's where we see if it's interfering with job, life, love, etc.
What are some of the symptoms of that tip? What should patients look for so that they know to come and seek care?
I'll just say, I think the important thing, if a patient notices, that's unfortunately sometimes a patient doesn't notice, but a loved one or a family member does first, is if, for example, an inordinate amount of time or emotional distress is tied to what they are either worrying about or stressing about, if they find that their behavior has changed, if they find that they're not coping so well or interacting with others, if they find that it's affecting their performance at work or their ability to even tolerate people around them. There are so many signs. It's really something that can creep up quite gradually and insidiously, and that actually happened quite a bit with the epidemic. But it's all about looking at changes over time in somebody's ability to interact with others and cope and function in the community as well as in their home. I'll let Jaleesa unpack it more because I know that she does wonderful work with her clients.
Thank you. I'm going to piggyback off of what Dr. Jimenez has mentioned. So sometimes clients don't even notice it for themselves. It may take a family member, a loved one to say, I find that whenever you were going through this or you're discussing this, I feel that you're showing signs of anxiety. So it's not something that you always see, or sometimes it's subtle. Sometimes it's irritability. Sometimes it's extreme fatigue, or if it's a lack of sleep, sometimes it's tearfulness, subtle signs. Sometimes you think to yourself, well, this is normal. And then someone has to say to you, well, I don't think it is. Maybe you should see someone. So there are different signs or symptoms that you should pay attention to if someone's bringing it to your attention, and definitely reach out for help. There's nothing with reaching out for help, to getting that assessment, having someone guide you and speak to you about it. It may be anxiety, it may not be, but nothing's wrong with reaching out for that additional support.
So do you think that anxiety can lead to depression?
Dr. Jimenez, or did you?
I feel like we were volleying. You go first, then I go first, but that's okay.
I noticed. I let you take the lead, and then I jump on.
The short answer is absolutely. Anxiety and high stress situations, particularly ones that are prolonged without breaks, can lead to essentially depressive states. And that can be full-on clinical depression, what we call major depressive disorder. And so absolutely, there can be a cost to protracted stress and anxiety, whether it's because of the sleep deprivation associated sometimes with severe anxiety, or impairment in functioning at work or with others, which then leads to somebody feeling down on themselves and developing pessimistic thinking patterns. Absolutely, there are multiple examples in which anxiety, particularly when it's not addressed, can lead to pretty severe depression.
One of the questions that I have, and Jaleesa, I'm going to give you a chance to piggyback off of that, is how could people, or how could institutions, not like hospital institutions, but work situations, like work, different jobs, have some kind of a screening to make sure that their employees are healthy, mentally healthy?
I know a lot of institutions, organizations, companies have a EAP program where an employee can reach out if they need that support. I do think that we could do better, reaching out instead of waiting for an employee to reach out, sometimes just doing the mental health screening. I do know Northwell has established something where on each unit, they check in with their, employees to make sure they're doing well. How are you feeling? Are you in the green or are you in the red? But not everyone may feel comfortable sharing that, right? They may feel, I don't want to be judged, or I don't want to be tainted as someone with negative outlook. So not everyone feels safe enough to share that. So I do think we can do better where, an employee can have daily access to reach out to someone to say, this is how I'm feeling, or a safe space where they can say, things aren't going well for me this week, and I do need that additional support.
You're 100% correct. I think especially in a work environment, people may not be comfortable sharing their personal feelings because they may get judged. And I find that especially people of color, Black and Latino people, we're very proud and strong people. And we are told to be stoic and we can handle everything. But I want to make sure that before this evening is done, that maybe we can put some phone numbers into the chat, or so that people have a resource to reach out to. Because again, we need to make sure that people who may not be working, or people who may be working part-time, or may not have an EAP program at their employment, that they have some kind of a connection. Because my concern is that we may lose somebody, and every life is so precious, right? Okay. And we need to figure out how we can help to guide that along. So what are some of the ideas or things you could think about that we can try and do within the community to make sure we're not missing some people along the way?
Education. Number one, education. And I will say that because a lot of clients that I have met with have had these symptoms for months before they decided to reach out to someone because they think it's normal. It's everyday stressors. It's what I've seen my mother go through. It's what I've seen my grandmother go through. So this is normal, that no one is able to share with them that there is support. There is help. There's the fear of being judged. It's we're Black women, or we're Black men. We're supposed to, or Latino, brown. We have this understanding that we're supposed to be strong always, and we're supposed to carry everything on our backs with a smile on our faces. And if you seek help, then you're failing your community. So we need the education. That's first and foremost, to say it's okay to get that support. That it doesn't make you any less of a woman, any less of a man, any less of a mother, a wife, if you did reach out for support. In fact, it's helpful because now you're teaching others around you that it's okay to get that support, and it improves the dynamic in the home. It improves your work performance. It improves your relationships with others. So I believe education is where we start.
Okay. Dr. Jimenez?
I couldn't agree more with Jaleesa. Thank you for putting it so eloquently. I think, education has to come in multiple forms and in different forums as well. There's podcasts and discussions like this. There needs to be community grassroots conversations about this. There needs to be, frankly, greater interest amongst our next generation of clinicians that are brown and Black to come up and join us in this conversation, so that more people see more people like them in the profession, and that breaks down some of the stigma and the fear associated with this. So I think from multiple dimensions or directions, rather, we need to be educating that this is real, this is important. There are resources, perhaps not enough, but there are some resources, and it's better to identify these things sooner than later. I particularly like Jaleesa's point that seeking out support can be a sign of strength, not so much vulnerability. And something that I talk about routinely with patients that I see who come to the hospital. I'll just mention very briefly that in my role, I work in a medical hospital, not a psychiatric one. And I see a number of patients, particularly from minority groups, who have never seen psychiatry, never seen psychologists, never seen counselors, but they were medically ill for some reason and in the hospital. And a consultation is asked of me. And I can't tell you how many times I have this, initial exchange about mental health. And my biggest role in that moment is, of course, to destigmatize everything and educate. And it's sometimes a little too late at that point, unfortunately, but sometimes it's at the right moment. And I think we need to find other opportunities like that, whether it's in medical hospitals or in our churches and communities or in schools or in places of employment, as you mentioned, to really provide these opportunities to educate and to sort of break down misconceptions of what psychiatry, psychology, mental health is.
I think both of you touched on a number of different important topics. Because again, like you said, a lot of this starts very young. And we learn to be strong and stoic and carry it. So I think it's important, like you said, to start getting people earlier, get into the high schools, and let them know it is okay to seek help. Even if they want to do it randomly. Of course, there are clinical psychologists within the high schools and the elementary schools. But again, sometimes their parents may say, hey, don't go because you may get judged, or, the teachers may view you in a different way. But again, I think once we start at that age level and make people comfortable, then they will continue as they get older to be more comfortable and be able to speak freely about their feelings and their inner emotions. So before we get onto the hard topics, what are some ways that we could potentially have mindful moments? Granted, Apple has put things into our watches, into our phones, but what are some of the things that both of you could share with the audience that you could do for a few minutes at a time?
Mm-hmm. Do you want me to start?
Please. Yeah.
I'm a strong believer in being intentional. So you have to say to yourself, maybe the top of every hour, I'm going to take 10 minutes for myself. I'm going to meditate. I'm going to spend, because Listen, this is my belief. The best relationship that you're going to have, one with yourself. So you have to take care of yourself better than anyone else is going to do it for you, right? You have to be mindful of the things that you say to yourself. Make sure that everything that you're saying is healthy and positive. So you take that time for yourself. You take the 5 minutes, you take that 10 minutes to just be with yourself, to see check in. How am I feeling? Because sometimes we're so in a rush, right? That things are happening around us and for us that we don't take that minute to just check in to see, how am I feeling? Did something affect me? Did something hurt my feelings? Am I hungry? Do I have a headache? Just take that 10 minutes to just check in with yourself. So I would strongly believe in being intentional, setting that time aside, whether it's 3 hours or maybe 1 hour a day, whatever it takes to make sure that you're checking in and loving on yourself.
Okay.
I couldn't agree more. I think the benefits that come from that intentionality or mindfulness are enormous. Not I think, I know. There's actually great research to point out that individuals who do this, whether it is 10 minutes here or an hour there, are going to live longer, are healthier, are happier, and have less, chronic stress kind of findings in them. And that actually translates also to some medical benefits too, believe it or not, lower blood pressure and less heart disease and all sorts of other benefits. And so I agree that it's important to do it. The challenge is that it can be difficult. And so the question is, how do you do it? And how do you remember to do it and whatnot? You alluded to apps and other tools. There's absolutely nothing wrong with using those to sort of remind yourself that you need to do this or to check in with yourself. Other people use other, mantras, Post-its, things like that. Or even, frankly, some people designate somebody as their accountability person, right? And say, hey, if you see me going this direction and turning hangry or whatever, call me out on it. And maybe you do it in reciprocal fashion for the other, right? And you sort of take care of each other that way. But in doing so, really enforce the practice of carving out mindful moments and checking in with yourself.
Okay. So how do you think we can work to find a natural way to, besides these mindful moments, to decrease stress? Because stress has increased since the pandemic. People are fearful of getting illnesses. Now we're being faced with monkeypox, COVID vaccines. People don't want to be vaccinated. We're into an inflation. So how do we work on stresses? How do we know which stresses can trigger our situations?
It's a great question. I'll start, I guess. This is going to vary from individual to individual. Some folks are going to be much more affected by health anxiety or illness anxiety, and some are less so. And so I think it's important to just be honest with yourself. If you think, that it's very important to monitor various epidemics and to be very careful and to be on top of vaccination status, and that's important to you, that's okay. Don't be, self-judgmental about it, but then check in and make sure that you're, pacing yourself with that and getting the resources that you need to navigate those things that you think need to be done around infection control or contagion. Conversely, if it's about inflation or something else, the same. It's going to be highly individual. I think that it's important to go back to this notion of functional impairment. If stress is really, getting you to change in some meaningful way with how you're interacting with others, how you're performing at work, how you're taking care of yourself, then maybe those stressors you're talking about have really gotten the better of you, unfortunately. And it's not a moment to, further judge yourself or beat yourself up over that. It's just a moment to reflect and then see if there's anything that can be done to change that state of affairs, if you will.
Absolutely.
All right. So if you had to say to a staff member, or you may have been running maybe a lecture on mindfulness to a group, what would be some of the words you would say to them to have them think about how to be non-judgmental of somebody?
I'll let Jaleesa take this one because I have a suspicion that she's guiding more people through mindfulness practice than I am.
Okay. Dr. Jones, could you repeat the question? I just want to make sure I'm
Sure.
understanding.
So again, sometimes people may, just because of bias issues or what have you, may want to judge somebody.
Yeah.
So if we were running a group session for whether it be a work or a church, how do we encourage people? What are the words we could use to have them say so that they're not being judgmental or thinking of somebody in a judgmental way, so that we can make it healthy?
I would encourage empathy, compassion to others. I would encourage changing your mindset, being more open, being more sensitive, whether it's cultural sensitivity or it's just being compassionate to your loved one. It's important for us to empathize because we never know what the next person is going through. And it's important to remember that at that moment, they just need support. They don't need your judgment. They don't need any condescending comments or criticism. They just need your support.
I think that's a great answer. Dr. Jimenez?
No, I was going to say, I'm sorry I put you on the spot, Jaleesa, but thanks for that wonderful and eloquent answer. I would add that it's not easy to be non-judgmental because our brains and our cultures and our societies are sort of making us all the time think certain ways. We're all susceptible to biases.
Of course.
So it's something that I think can be packaged using Jaleesa's terms about being empathic for others, but also making it almost a challenging exercise for one to earn that skill, to practice it, to gain that skill. I've met many individuals who kind of get excited about this new challenge, something they've never really thought about, how I can be non-judgmental, not only of others, but also even of myself, my own thoughts, my own reactions. That non-judgmental practice is a very difficult thing to achieve. And yet, if you make it an exciting and wonderful project, if you will, to aspire towards, then a lot of people can get behind that.
Absolutely.
Sorry, it's so funny because, again, I like those aha moments when you bring it out when people are starting to be judgmental, and then you bring it to their attention. Hey, if you look at it this way, maybe you could see what that patient or even that person may be experiencing. And then you go, oh, I never thought of it like that. Mm-hmm. So, it's just trying to remember, and anybody can do that, right? It could be the person next door, because again, we tend to want to judge people at all times because that's just normal, but it shouldn't be normal. So it's working, like you said, both, Jaleesa and Dr. Jimenez, on how do we reflect within ourselves to get to that aha moment.
And to remove the shame about it, similar to what Dr. Jimenez said, because it's a normal, natural response to at times be judgmental or have some type of bias. So to remove that shame and say, hey, I don't think you're a bad person because you have this bias, but let's break this down. Let's put yourself in someone else's shoes, help you to understand that maybe they have a different perspective or they're going through something different than you. And I think once you remove that shame, people are more open to saying, okay, you're right. Let me look at it at a different perspective. So almost normalizing how they feel, but then also giving them space to have insight and to see how someone else may be feeling.
I think that's a perfect answer. And when that light bulb of the aha moment comes on, you could see how they interact with other people later on and how they've made a change.
Can I add one more dimension to this? I think this is a very important topic we're on. I agree with Jaleesa. There's all sorts of shame and immediate reactions that come with somebody noticing themselves potentially being biased or judgmental. And yet it's very natural. I think the simultaneous thing to do is to excite people to free themselves from this natural tendency, right? I think most people walk around thinking that they're pretty free, autonomous kind of people that aren't governed by much, and they're set in their ways, and they're all of that. But we're all, if we're going to be humble about it, we're all very susceptible to pressures outside and internal. And again, it can be an exciting prospect or a really fun proposal, life-changing even, to tell somebody that actually maybe you're not in total control, and it would be nice to free yourself from those sort of internal signals. And an aha moment can happen in that respect, where a patient, a client, a member of our community can say, whoa, wait a second, I haven't really been in full control, and I do want to be in control. So let me examine this tendency that I have to look at things in a certain way.
I love that perspective, Dr. Emmett. Love it.
And, I think that's the most important part when we get into these engaging conversations and we get that out into the community. I think those are the roots that we need to implant in to get that growth. And that's how we can start to make change, right? What we're going to do is we're going to take a very short break and come back, and we're going to start to dig a little deeper into this questions. Okay.
You're listening to All About Us Radio. We're live streaming 24/7, playing old school versus new school. Follow us on Facebook, Twitter, Instagram at AAU Media, and visit our website www.aaumedia.com. Call us at 1-833-369-1444, extension 1, and leave us an inspirational message or request. You're listening to All About Us Radio.
Throw and Tuck. It's handmade by myself, and you only can get it here, and it's patent, and it's only here at Rococo Design. It's like a regular pillow, or you can take the blanket out like so, fluff up the pillow, open up your blanket, wrap it around yourself, and then you can lay on your sofa and relax with your pillow, throw and tuck. When you're done with it, just flip it over. When you don't want the blanket anymore, you just fold it over twice. Fold it over twice again. Fold it over. And tuck it in the back. And there you go. You're back to the pillow, throw, and tuck. Rococo Design.
You're listening to All About Us Radio. We're live streaming 24/7, playing old school versus new school. Follow us on Facebook, Twitter, Instagram at AAU Media, and visit our website www.aaumedia.com. Call us at 1-833-369-1444, extension 1, and leave us an inspirational message or request. You're listening to All About Us Radio.
Oh, thank you, and welcome back. So I want to dig deeper into some of the psychiatric conditions that are affecting our Black and Latino patients requiring hospitalization. So, Dr. Jimenez, I want to talk to you a little bit more about schizophrenia and what that is, and what should people look for, um, and when should they start to seek care? What are some of the um, presentations that patients can present with?
Sure, thank you. It's an important topic. I'm going to start by actually emphasizing that once again, I'm a physician, and I think as a physician, not even as a psychiatrist, when I think of these conditions, schizophrenia is a very serious medical condition, first and foremost. I think there's a misconception out there that maybe somebody with schizophrenia is either faking it or has, just bread and butter stress, or can just kind of walk it off, or maybe can get well with a few changes in their life. But it's actually a very serious medical condition that requires medical attention, medical treatment, just like other medical conditions, heart disease, kidney disease, etc. There are brain diseases, and schizophrenia is one of them. It is a condition associated with abnormal thinking patterns and behaviors, as well as perception changes, meaning seeing, hearing things that may not be present, as well as other really strong, scary emotions, fear, paranoia, and aggression sometimes. It's a complicated condition that can present differently from one individual to another. But what is definitely shared by all cases is that it's beyond their control. It's really not a choice. It's not a moral failing. It's not something that the individual is bringing upon themselves. It's a condition associated with neurologic changes, brain changes, genetic risks, and other medical and biological factors. It's very serious, and essentially the things to look out for, the other part of your question, involves changes again in thinking, in personality, in attitude, in how people interact with each other, things like changes in self-care, socialization. Of course, some of the more dramatic things, talking to self, perceiving things that may not be there, feeling afraid of things that others aren't noticing or afraid of. There can be a number of those signs, and it can happen gradually over the course of months, sometimes even years in some cases. But it can also happen pretty quickly, unfortunately, in certain cases where something accelerates the process. And in this respect, we have a few hints from medicine that we've learned over the years. For example, unfortunately, certain substance use patterns can activate schizophrenia and other psychotic disorders like that, sort of blossoming, if you will, adding fuel to the fire, and then boom, the condition kind of presents itself. And that one can, in that instance, it can present a little faster. But that's sort of a quick description of what it is. Again, to emphasize, because I can't emphasize this more, it's a medical and neurological brain-based condition that needs serious medical attention.
So, three things I kind of pulled out of there. At what age range do you see is a common age range for the diagnosis of schizophrenia?
It's a great question, because it is not something that develops at any age range. It's by far the majority of cases are in young adulthood, ranging from about 17, 18 through about 30. There are slight differences in that age range for women and for men. But that's really the big chunk of time. And the reason for that is because our brains actually go through all sorts of changes as we develop, from childhood, infancy, childhood, adolescence, puberty, etc. In adulthood, there's beginning of adulthood, there's a change in what's called pruning. It's a technical term, but our nerves in our brain stop changing, if you will, and they sort of cement. Most of our personalities cement or sort of get fixed in our 20s. Same thing with certain brain-based disorders, and schizophrenia, unfortunately, is an abnormal development of those brain pathways. So to answer your question, young adulthood, 18 to about 30, is the really hot time when you can see changes in an individual and when they can unfortunately be diagnosed with schizophrenia.
Okay. One of the other things you mentioned was genetics. Is there a genetic component to schizophrenia?
Yes, there is. Thank you for bringing that up. And that's important because, as with other medical conditions, conditions that have genetic components are clearly not in our control. These are things that are inherited and predispose or set up somebody for disease. There are genetic factors to certain cancers, to certain conditions like diabetes, etc. And in mental health and schizophrenia in particular, there's also the same. We don't have one single gene to say that is responsible for schizophrenia. But what we do know is that individuals that have family members with schizophrenia, unfortunately, are at higher risk for developing it themselves. So that's another piece of education that's really critical. If somebody in our community has a mental health condition or a relative with a mental health condition, they need to be extra careful because they could be walking around with a little bit of inborn risk
Got it.
that is not up to them. It wasn't something they decided. It wasn't something that they chose.
And you also mentioned substance abuse. What are some of the substances that are out there that may trigger or push a patient into exhibiting schizophrenic behavior?
Yeah, it's a great question, and it's not entirely elucidated. It's not entirely figured out at this point, but we have some signs to suggest that if somebody has a risk, for example, genetic risk factors, and they have severe trauma, perhaps they have severe stress, and use certain substances, then their risk for developing an irreversible condition like schizophrenia is very high. And the drugs that have been implicated more often than not include those in the what we would call sort of hallucinogenic realm, meaning ones that already by themselves produce a break from reality during intoxication. And that includes cannabis, marijuana, synthetic cannabis, which is an unfortunate epidemic currently that we're seeing, and other hallucinogenics like LSD and these various other substances.
Wow.
It is less commonly associated with, say, cigarette smoking or alcohol necessarily, but it's not impossible. There's more of a signal, if you will, or more of a pattern that you see with these hallucinogenic medications and drugs, marijuana, etc.
About a year ago, marijuana became legal in New York, New Jersey, tri-state area. Are you seeing an increase in the number of people um, that are triggering or becoming um, in the diagnosis of schizoaffective disorder or schizophrenia?
It's a great question. It's a controversial topic because marijuana, has loaded history and has some health benefits in certain patients and certain scenarios. So I don't want to, first of all, just don't want to mischaracterize the entirety of marijuana. And clearly, our social, cultural sort of community has voted in favor of its use. That being said, I think in those who have certain inborn risks, it may not be the best idea to use marijuana, or at least not lots of it. To answer your question, I haven't measured myself or conducted studies to measure if there's an uptick in marijuana induced schizophrenia,
Hmm.
but I wouldn't be surprised if we saw that. What I have seen, despite the legalization of marijuana, is more cases of what's called synthetic marijuana psychosis. And that's actually a real big problem where perhaps, kids, young adults experiment with bread and butter marijuana, but out of peer pressure or societal, you know, wanting to fit in, etc., they tip over into synthetic marijuana. and get past the sort of usual marijuana that we all sort of agreed, I guess, to legalize. In the synthetic marijuana, we unfortunately have other compounds that are not regulated, that are really kind of a black box. And I do see more individuals using that tipping into schizophrenia.
Got it. Um, what are you seeing with respect to dealing with the senior community? Unfortunately, our seniors are kind of caught between, I'm seeing doctors, but I also need additional help. And it makes it very difficult because of lack of access to care. Sometimes they can't get there. So, how and what changes are you experiencing with the senior community?
It's a great question, and it's a different demographic kind of epidemic that we're facing. Unfortunately, seniors are very vulnerable just by the fact that they are, of course, older age. Their health is not as robust as it used to be, and we've seen with COVID and with other social political variables a decline in resources for the elderly. And as they get older, they get less support. They get less, for example, attention in even structured environments like nursing homes, where staffing crises are resulting in poor outcomes. So I think it's a real challenge as our population ages further, and I think what is desperately needed is more sort of differentiation of levels of care. So we have nursing homes, we have home aides, but we need different levels. We need, for example, adult daycare programs, more of them, to help individuals stay active during the day and remain at home, but still have some interaction with others, which can be very healthy to forestall issues. We need that in place, in my opinion, to prevent the decline that we're seeing, the rapid decline or faster decline we're seeing these days, as individuals are left alone in their homes without much support.
Mhm.
Obviously, the COVID pandemic accelerated this and made it a really tough time, as they were deathly afraid, rightly so, of interacting with society because they're the most vulnerable population for COVID infection. But in the meantime, slowly and insidiously, they were declining and facing serious consequences later.
I see. And as we tip into one of the other medical conditions, bipolar disorders, can you describe that for the audience, please?
Sure. So bipolar disorder was formerly known as manic depressive disorder, and that's what the two poles refer to. It describes really wide swinging mood states and energy states that are not usually compatible with good functioning or healthy behavior. And so somebody can fluctuate from a depressive state where they're not doing much, they're not interacting, they're not caring for themselves. They may be hopeless, pessimistic, and even suicidal. And then on the other end, the manic state can be quite problematic, but associated with enormous amounts of energy, productivity, irritability, anger, agitation, reckless behavior, things that can put them into a lot of danger, or even uh, emptying out their bank accounts, doing reckless things that unfortunately later they'll regret. In either of these poles, the individual's really not in full control. They're governed by a neurological and psychiatric state, and it's also a serious medical condition like schizophrenia, deserving of medical attention, assessment, and therapies, including medications.
Okay. And Jaleesa, when you come up with patients that may need additional care or help, how do you make that determination? I know you said you do some, you know, testing and what have you. What are some of the things that would say, okay, I need to have this person reach out to a physician like Dr. Jimenez?
Sure. So that's a great question. On our first assessment or first meeting, we do an evaluation. And so we would assess for the client's strengths, their weaknesses, their stressors, their coping mechanisms. And we will determine at that point whether or not we feel as though we need to bring on a psychiatrist from the very beginning. If during that assessment, if the client doesn't meet the criteria, and then I start with individual therapy, even, during our sessions, if we find that psychotherapy and discussing coping skills and such as grounding techniques and deep breathing, if we've evaluated or assessed, then we find that the coping skills aren't working, we definitely will bring on a psychiatrist at that point, because they may just need that additional support for medication management.
And that's a question that I have for you, Dr. Jimenez. Sometimes when patients feel like they're being placed on medication, is it true that they have to stay on medication? Can they end up getting some outside additional therapy and may be able to eventually come off of medication? Is that a possibility?
It's a fantastic question. And I said sort of pretty sternly that these are medical conditions deserving of medical attention, but obviously in concert, they deserve psychosocial interventions, coping strategies, environmental support, in concert with the medications. To get to your question, the management of these severe psychiatric disorders is usually 3 phases. Acute, meaning when there's a crisis and somebody really is not doing well, and that may require inpatient psychiatric care or hospital-based care temporarily, medications, etc. Then there's sort of a subacute phase, which is after that, being stabilized and still on medication, but seeing an outside psychiatrist, doctor, perhaps therapist as well. And then there's so-called maintenance phase. And the maintenance phase is a sort of a really healthy phase where somebody is examining the need for medications, supplying themselves or building themselves up with coping strategies and various activities that keep them healthy, maintaining a social rhythm and a pattern to get out of repeat episodes of either mania, depression, or psychosis. And that maintenance phase is a highly individualized, recovery-based phase. And some individuals may have lighter degrees of burden and may be able to come off of medications. I don't want to suggest that is an enormous number if you have a serious case of schizophrenia or bipolar disorder, but it is possible with the right psychosocial supplementation and with enough time and observation, and doing that safely.
So
I just want to, I'm so sorry.
Julissa,
I just want to point out for individuals with the diagnosis of bipolar or schizophrenia, if they were ever seen by a psychiatrist, we definitely collaborate with that psychiatrist to see what phase that client is, in. As Dr. Jimenez mentioned, the acute, subacute, and so we definitely collaborate. And even if they haven't, we definitely do make a referral to a psychiatrist so they can have an evaluation to determine whether or not that client will need medication now or if psychotherapy is appropriate at this stage.
Okay. There are a number of people that want to try holistic ways of doing treatment. Are there any things that you can talk about or discuss regarding using holistic management before having to proceed to a pharmacological medication?
It's a great question, and I don't fault anyone for wanting to explore holistic, or another term that we sometimes hear, integrative approaches to not only mental health concerns, but also medical ones. I think it's very natural to want to put less unnatural things into your body and all of that. So back to our non-judgmental stance, I think it's important to apply that for somebody who is asking about these things. But it's also important to be very scientifically rooted in our opinions. And there are certain conditions that, again, are very medical with a capital M, if you will. And those conditions may not respond much at all to holistic therapies. if holistic therapies are used in concert with other strategies that have been scientifically, vetted and proven to help with the condition, because again, these are medical conditions that have associated treatments, then there's perhaps nothing wrong with using that as a tool to supplement the care. I would say that it's important to have a just open, honest discussion with your provider about it. But just as they are curious about your holistic strategies that you want to integrate, be curious about what they have to offer too.
So I
Absolutely.
think you brought up a great question because, again, I find that our Black and Latino patients are always afraid to ask physicians or any providers about what their care is going to be, what medications you're going to put me on. And then when they leave, they choose not to want to take it because they didn't have a robust conversation with the doctor as to why. Why do I need this? Why? What would it do to help me? So, how would you approach, or what would be some key things that you would leave or tell the audience they should ask their doctor before a prescription is given to them, especially a psychological a medication?
It's a great question. I think it's important that patients demand to learn as much as they need to feel comfortable before deciding taking or not taking a medication. I think it's important to demand that of your physician, that he or she provide a reasonable explanation as to how this specific medication is going to address whatever symptoms or functional impairment or condition you're talking about. And I think each person's going to need some of that or more of that, less of that. It's also good to do your own independent research, but to also remember that there is so much out there in the internet and in the news that it's a good idea to look for pretty well established and vetted sources of information. Aside from COVID and a few other phenomena recently, the other big phenomena that we've all faced is the phenomenon of misinformation, right? And
Mhm.
there's a lot of medical misinformation out there. And so I think, to answer your question, I think we should hold our physicians accountable to explain during the visit or whenever you're having this dialogue why exactly this medication. Besides, that's what you and your insurance are paying for. And then also compare that with what's out in well-vetted sources of information, and do your own research. I think doing it from two ends like that is better than only one.
Absolutely. So, as we're getting close to the end of our session here, I'm going to ask both of you, if you were given, I don't know, the $1 billion that was happening with Lotto, what would you do, Jaleesa, to change mental health in your community? And what would be your takeaways for the audience?
Wow, loaded question. Great question, loaded. First step, as I mentioned before, education. I believe in educating our community. I think there's, as Dr. Jimenez just mentioned, there's so much misinformation out there on the internet. And I think it's important for us to provide, we have the podcast, right? Have all these other platforms, but if we can just get the information out there even more, remove that stigma, remove that shame, make it inclusive, make people feel comfortable with seeking the treatment and the help that they need. I think that would be my first step. And then once we get there, now we have to create resources. We have to create places where they can actually access this help that you keep speaking of, right? Now everyone is excited about it. So where can I go to get help? So we have to make sure that we provide more trainings to our clinicians. We have to make sure we have more spaces where these people can go and feel safe and comfortable to get the treatment. So my first would be education, and the second is to provide more resources.
Okay. And takeaway for the audience?
Get help. The first thing I would say is just to get help. And what I mean by that is there's sometimes you're going to be feeling things and you might say that these are normal, or I've seen everyone around me go through this, but you don't realize how it's impacting you as a person. It's impacting how your job performance. It's impacting your family and friends, the dynamics, even with your children, marital issues. So seek help. Nothing's wrong with making that call, seeing a clinician, and getting that assessment. And also, don't stop. If the first clinician doesn't fit you, then don't say to yourself, it doesn't work, or this isn't for me. Don't give up on yourself. Clinicians, we're human. We all have different trainings and different backgrounds. And so just as you go on a date, right, you meet someone, they're not for you, you don't give up on that. Don't give up on yourself. Keep going. Find the right person that's for you. Get the help that you need and remove all that shame and stigma. Get the support.
Excellent. And Dr. Jimenez, same for you. You got the $1 billion lotto ticket. Okay. What would you do within the community, and what would be some of the takeaways?
Yeah, it's a great hypothetical. I think what I would do is invest in community sort of champions that kind of sort of go into these various settings, schools, job placements, town halls, churches, and set sort of a tone and provide a presence for those who are curious about mental health. And these champions might be, clinically trained, maybe not, maybe they are culturally sensitive and trained in speaking to these individuals. I think we need that bridge. I agree with Jaleesa that we need more care, but even with some care that we have now, there are still many cultural and social barriers. And I think if we have some folks who are excited to, take care of some of the systemic issues in their communities and are themselves champions and understand that by helping their fellows in the community seek care, they might get excited, and then that can turn around into more utilization of care. And the other thing I mentioned earlier, if we have $2 billion, not just one, is a ton of scholarships and other exciting opportunities for those who are Black and brown and of all walks of life to get into mental health care as clinicians, as social workers, doctors, you name it, all of that, because I do think that makes a huge difference when more individuals are doing that, and not just because they might be there waiting to provide care, but more people hear about, oh, so-and-so is actually training to become a psychiatrist, or so-and-so is becoming a psychologist. Isn't that interesting? Rather than that being the weird anomalous person in a minority group, right? I think it should be fairly common, frankly, just as individuals become policemen or accountants or whatever, or work in retail. And so I think that's very important from the ground up, facilitating it with those hypothetical $2 billion that you're going to send over to me.
So I wish I could.
To add to that, I think, I'm sorry, Dr. Jones, I just wanted to add So I also think that we need to do mentor programs, and not only in high school, but even younger. I think it needs to start, because I find that even young 5-6-year-olds, they're able to express themselves in ways that I feel like, not everyone was able to do at that age and that stage. So I think that we need to encourage that and make sure that they feel safe enough to say, I don't feel well today. I'm not sure what it is, but I don't feel. Give them descriptive words, I think. And then also with the mentorship program, starting as young as 11 and 12. So they're exposed to other clinicians, or exposed to people in their community that are going for mental health, and they are able to say, I actually like this and I want to do this for myself. What I found is that a lot of people will enforce, being a doctor and being a nurse, and these are great professions. I work with doctors and nurses. I love them. However, not everyone is exposed to, a social worker. And if they are, they only have one example of what a social worker looks like, which is working for, ACS or CPS. And so when you meet someone and you say social work, they immediately think, oh, you work at ACS. As a mental health clinician, people process and cope. And, so I think mentorship is so important in these communities, so that people learn and understand, and they have something to strive toward.
I think you both touched on key points. I get so many calls on, can I find or provide patients with, a Black or Latino, psychologist, psychiatrist, licensed clinical social worker. and because people want to see people like themselves, they feel that they can relate better. So I agree 100%. And I wish I did win that lotto that I could share and make it work. But I guess we might have to find different avenues to try and, get into maybe getting grants. But this is so important. And it's something that's very dear because I think we all know of somebody who's been challenged or diagnosed, whether it be within our family or close friends. And so that's why I felt that it was so important to have a topic on mental health and how it affects our community. So I want to thank both of you guys for sharing your time with me as well as the audience tonight, just to touch on these topics and, you know, get the information out there. I'm going to see if we can type into the chat. Jaleesa, do you have a contact or do you have an email that if somebody wanted to reach out to you, that they could? And Dr. Jimenez, the same as well. If they needed resources within the hospital setting, can you please supply that information? And can you just say it slowly so we could try and if you could type it within the chat here, we'll get it out to the audience.
I'm going to put it in for you now.
Thank you. So we're going to bring the show to a close. I'm going to ask that Dr. Jimenez and Jaleesa, you guys stay on, but we're going to close out the show. Thank you for a lovely evening.
Thank you.
Thank you.
You're listening to All About Us Radio. We're live streaming 24/7, playing old school versus new school. Follow us on Facebook, Twitter, Instagram at AAU Media, and visit our website www.aaumedia.com. Call us at 1-833-369-1444, extension 1, and leave us an inspirational message or request. You're listening to All About Us Radio.